Hello and welcome back to Obcast. This video is going to cover miscarriage or early pregnancy loss or failed intrauterine pregnancy. Again, this is the reason why women with early pregnancy bleeding come to the emergency department. This is their fear. And it's not uncommon that they do in fact have an early pregnancy loss, and therefore I think it's important that in primary care or the emergency department or small peripheral hospitals, we have a good understanding and give the patient a good idea of how their care is going to progress and what their options of further treatment will be. I think the first thing to say is that miscarriage is really common. Around 20% or 1 in 5 pregnancies will end in miscarriage, and there's a lot of, society doesn't talk about this a lot, and therefore it's often a surprise to women when you say that this is a really common thing. By age 40, about a quarter of women will have had a miscarriage. So it's something in the community that's happening to a lot of our patients. Now, the presentations to the emergency department are usually either vaginal bleeding and or abdominal pain, or even just an incidental finding of a missed miscarriage on ultrasound. And this is usually a dating scan, but also might be a nuchal translucency scan done as part of combined first trimester screening. Thought we'd cover some classic definitions for miscarriage. I've got a table here to demonstrate them. Now, traditionally, miscarriages were classified based on their cervical changes and whether or not any products have passed. And I guess conceptually this is still helpful, but it's becoming less and less used as strict criteria. If we just go through them quickly at the top there, the threatened miscarriage. Now that's actually when there's symptoms of miscarriage but a live baby that is viable. And so in those cases the cervix is closed and no products have passed. From this point, it really is a progression of symptoms from not having a miscarriage, which is really what a threatened miscarriage is about, to completing a miscarriage. And therefore, in between that, we have the incomplete miscarriage, and that is where the cervix is open and products are starting to pass, but there are still some retained products of conception. And that's really a timing issue as to when we become involved, because this may be just a normally progressing miscarriage that is going to complete normally, or it might be one that has, followed a protracted course and therefore might benefit from intervention. A complete miscarriage is one where the cervix is now closed, the products have all passed, and the uterus is now empty. And that can be a clinical or sonographic diagnosis, but increasingly it is a sonographic diagnosis. And a missed miscarriage is when there's been a pregnancy loss, but no process has begun to expel the products of conception, and therefore the cervix is closed and the products have not passed. And the ultrasound findings will then be consistent with a failed pregnancy, but that might take the form of a fetal loss or embryonic loss, and we'll discuss some of those in a couple of slides' time. Now, there's other definitions, such as an inevitable miscarriage. Now, I don't think it really has a role in clinical assessment and diagnosis anymore. This was just when the cervix was open, but not yet any products had passed. And there's the septic abortion or infection of a miscarriage, which can really complicate any of them, but most commonly an incomplete miscarriage. In terms of patient assessment, as usual, it follows history, examination, investigations. In part of exam, it's important to remember the vital signs, and some miscarriages can be associated with either profound hemorrhage or even cervical shock, or, as we just mentioned, can be complicated by secondary infections. So the vital signs are important, as is the abdominal exam. And now, in terms of the vaginal or speculum exam, things that can be helpful include assessing for changes of the cervix, for evidence of infection via uterine tenderness, malodorous discharge and or cervical excitation, but also the removal of any cervical products. And if the products are right there at the external os, it can be helpful in reducing ongoing bleeding, but also in the presence of cervical shock, removal of those products really is the emergent treatment to normalise the hemodynamic status of the patient. In terms of investigations, these women usually will get a hemoglobin level, a group and hold, and a blood count. And a beta HCG. The group and hold really having two possible benefits: that of preparing for blood to be transfused in the unlikely occurrence of significant hemorrhage, but also to guide any need for RH immunoglobulin. As with all early pregnancy complications, the transvaginal ultrasound is the imaging gold standard. And it's important to note that point-of-care ultrasound is increasingly a very useful modality for early pregnancy assessment, but to diagnose a failed pregnancy formally, a transvaginal scan by an experienced operator is required. I thought I'd talk about the failed intrauterine pregnancy criteria. Now, these are set out in Australasia by the Australasian Society of Ultrasound in Medicine. And I guess the two most important findings to remember, as you might get these reports back in your practice or emergency department, are that if a woman has a mean sac diameter of more than 25 millimetres without the development of a fetal pole, that is consistent with a failed pregnancy. And we'll talk in a minute that this is what used to be called a blighted ovum, or is now increasingly referred to as an embryonic pregnancy. Another clear diagnostic criteria for failed intrauterine pregnancy is that if a fetal pole has developed and there is a crown rump length greater than or equal to 7 millimetres with no cardiac activity, then this is a failed pregnancy. And I guess the background here is that when the crown rump, when the fetus starts to develop and the crown rump length is 2 to 3 to 4 millimetres, it's usually very clear very early, the cardiac activity, and sometimes these fetal poles look like they're just one heart beating without really much baby around it. And so the 7 millimetre cutoff is actually quite conservative. Now, there's some other interim criteria, and they can be used if you've got a suspicion of early pregnancy loss, but they don't meet the above criteria. And that includes that if the crown rump length is less than 7 mils and there's no heart activity, then if you repeat the ultrasound in 7 days, there should be cardiac activity. And if this isn't the case, it's also consistent with a failed pregnancy. Now, if you have a mean sac diameter of more than 12 millimetres, if you repeat, and no fetal pole, if you repeat that in 1 week's time and there's no fetal pole, then this is also a failed pregnancy. If the mean sac diameter is less than 12 millimetres, so quite small, and no fetal pole, well then in 2 weeks, if there hasn't been a doubling of the mean sac diameter and the presence of a fetal pole, this is a failed pregnancy. So really the two that you need to remember are mean sac diameter over 25 millimetres with no fetal pole, or a fetal pole greater than or equal to 7 millimetres with no cardiac activity. Because when either of those are present, you can diagnose a failed pregnancy. And truthfully, the minor criteria below are ones that are best looked up when you're thinking about utilising them, because they're a little bit harder to remember. Now, we mentioned an embryonic pregnancy. I just wanted to touch on this briefly. I think it's quite easy to understand why fetal pole without cardiac activity represents a failed pregnancy, but sometimes I find people have a little bit of trouble conceptualizing an embryonic pregnancy. And as we mentioned, this is when there is a gestational sac but no fetal pole develops. I've got some pictures here, and this shows the uterus with a gestational sac, and there is no fetal pole within that gestational sac. Now, the mean sac diameter is measured by taking three-dimensional diameters and taking an average of that. And you can see in this case, the mean sac diameter was 26.2 millimetres, and therefore consistent with a failed pregnancy, and this woman underwent a suction evacuation. Now, in terms of the management options, it's important to consider several factors. First of all, is the woman unstable? Is there presence of infection? Is there an intrauterine contraceptive device? Or is there suspected gestational trophoblastic disease or suspected molar pregnancy? Now, if any of these are present, really these women need a suction evacuation or surgical management of their miscarriage. And obviously in the setting of an unstable woman, they might need resuscitation and or removal of cervical products. And in infection, they might need antibiotics and fluid resuscitation and or vasopressors. But really just in terms of choosing the modality of definitive management, these few factors need to be considered. Now, if none of these are present, then there's three main management options, which include expectant management, medical management, and surgical management. And also, just to remember that for women with established miscarriage, Rh immunoglobulin is indicated for those who are Rh negative. And the dose in first trimester is 250 international units given intramuscularly. Now, in terms of these three main management options, I guess the summary from a lot of literature is that, the first trial that really looked at comparing these head-to-head was the MIST trial, which is just over 10 years old now. And I guess I think the most basic take-home from the MIST trial is that they're all reasonable options. They have their pros and cons, but in the absence of instability, infection, suspected molar pregnancy or intrauterine contraceptive device, it really is then time to sit down and have a conversation with a woman and her family about the pros and cons of each of them, and then making some shared decision making from there. Just to summarise these three options, and there's a bit of detail on this slide, but hopefully it forms a good memory aid, is that in terms of conservative management, that's just watching and waiting and allowing the miscarriage to progress naturally. And these women should be given oral analgesia and some clear return precautions to the emergency department, and things like very heavy bleeding or severe pain, or if they're concerned about the severity of either of those symptoms, if they have a temperature. It's important that the women who choose this understand that they can change their mind and escalate to a different form of management if they would like, and a good early pregnancy system will at least follow these women up over the phone. In the MIST trial, it found that the need for a suction evacuation was relatively high with conservative management. Now, it was about a quarter of women who had an incomplete miscarriage and about half of women who had a missed miscarriage. And I think it's easy to understand why an incomplete miscarriage might be more successfully treated conservatively, as that process has already commenced. And you'll find that with both medical and conservative management, they're both about twice as effective in the setting of an incomplete miscarriage. If we go back now though to the figures of 25% and 50%, I think those, failure rates are overrepresented by the fact that these women in the MIST trial were randomised to one of the treatment options, and they were given a choice to change treatment during the study. So I think these rates will be lower with a good consultative discussion with a woman who then chooses her modality of management, if that makes sense. And then the other thing to remember is to follow up the beta HCG levels until 0. Now, in terms of medical management, the principle here is that misoprostol is used to open the cervix and initiate contractions, and it's used with 1 or 2 doses of 800 micrograms of vaginal misoprostol. Some centres will use a smaller dose, but this is the most common protocol. Now, these women need to understand that the misoprostol can cause a little bit of shakiness, can cause contraction pain and bleeding, and they need to be and even nausea, and they need to be given some supportive treatment agents like oral analgesia and antiemetics. Now, the markers of success of medical management are obviously the initiation of contractions and passage of products, but also usually a beta HCG levels done at baseline and then after a week, just to try and make sure that level is dropping. And an ultrasound may be done to screen for incomplete miscarriage, I guess, if there are symptoms of retained products or a less than 90% fall in beta-HCG. The failure rate of medical management's quoted in the literature to be somewhere around 15% for missed miscarriages, and it's more successful in a incomplete miscarriage, again for the same reasons that make sense with conservative management. Now, I have quoted the infection risk across all three arms. This was actually the primary outcome measure of the MISS trial, and they're all around 1 in 50, and so not requiring prophylactic antibiotics. If we finally go to surgical management, well, this is done via suction evacuation of the uterus with a suction catheter. It's considered the definitive management, and it's indicated, as I said before, at patient preference, but also if there's instability, infection, an intrauterine device which needs to be removed, or if there is suspected gestational trophoblastic disease. It has some risks that don't exist with the other treatment modalities, such as uterine perforation and Asherman syndrome. These are both rare conditions but need to be considered in the context of the individual patient. And then products are generally sent for histopathology, and the beta-HCG levels don't need to be followed up in these women if they've had a definitive evacuation. The last thing I want to touch on is the psychosocial impact and management of these women. And I think it's just a bit, I guess, overwhelming when to see these kind of numbers, and that is that depressive and anxiety symptoms in women after an early pregnancy loss can be up to half. And I think superficially we understand that as a community and a healthcare system, but the suicide rate after early pregnancy loss is, twice the background rate in some countries, and this was studies done in northeastern Europe. And that really the psychosocial effects of this to a family or a woman might be more significant than the medical effects. And obviously we're very much trained to think about the management options that I've just, gone into detail on, but these things are really important. These things need to be addressed up front, whether that's in the emergency department or primary care. And I think it's important to have access to and know what your local support services are so that women can leave the clinic or the emergency department with some information. Well, that concludes the discussion of miscarriage. I hope it's been helpful and enlightening, and thanks very much for listening.